Thank you very much. It's such a privilege to come to this forum. And I heard Devanshu say yesterday that they were overflowing and the chairs had to be kept outside the hall. I wonder, the lunch was too heavy and how things are, but I hope that more and more people would join in. So what we have done for this session is that we have an esteemed panel over here, and it's well represented, which just highlights the fact about a multidisciplinary team which is required for managing this colorectal cancer. So we have Dr. Kamran Khan, who's the surgical oncologist, Dr. Nagesh is the medical oncologist, Dr. Romesh, you said, no? Bhupesh.
Dr. Bhushan.
Bhushan, Dr. Bhushan. Sorry, I'm sorry because you came in at the last minute. He's a radiation oncologist, and Dr. Prasanjit is a pathologist. What I'm going to do is I'm just going to take you through a couple of cases, and we'll discuss all the issues which are involved in. Okay. Welcome, sir. Thank you very much. So, can my slides are here. So, we'll start off straight away. This is a case of a 67-year-old lady, multiple comorbidities, presenting with GI symptoms and incomplete evacuation, weight loss over a period of 3 months. ECOG-1, BMI 27.3, and on per rectal examination, there is a growth palpable 4 centimeter at the anal verge. From 11 o'clock to 3 o'clock, it's immobile and hard growth. These are the basic investigations. So CEA is 25 nanogram per ml. HbA1c is good. Albumin is 4.1. Colonoscopy showed a growth in the lower rectum, half luminal circumference involvement, and the biopsy was moderately differentiated adenocarcinoma and with MMR proficient. We all realize that the greatest impact in the last decade has been with the MRI. And although the patient came with a CT scan which showed certain findings, the MRI was done. I just want a comment from my panelists, maybe Dr. Kamran and Dr. Nagesh, in terms of how you view the MRI as how it is added to your clinical practice.
Yeah, so I think for a localized rectal cancer, non-metastatic disease, the most important thing I bank on is a good per rectal examination. I think that's already been done. But I must stress that a good per rectal examination gives me almost as much information as an MRI. I'm able to judge the distance from the anal verge, relationship to the vaginal wall, prostrate, lateral pelvic wall involvement, mobility. But of course, MRI is part of the workup if it's a non-metastatic disease, and we are planning neoadjuvant therapy. On MRI, I'm looking for possible breach and involvement of the mesorectum and any nodes or extra mesorectal spread involvement of the lateral pelvic wall. So basically the TNM staging.
Yeah. Dr. Nagesh, anything you add?
Yes, sir, totally agree. For T-stage, N-stage and mesorectal involvement, MRI is better.
So I think it's now evident beyond doubt that it is the best test in terms of locoregional disease to evaluate the rectal cancer. And in this patient, as you can see in these images, there is an extramural extension. There is involvement of the levator ani, as you can see here. So this is a locally advanced with nodal disease, as you can see over here. So I'll pose a question to the audience at this point of time, and we'll get the panelists to get involved in this, that FDG PET in patients with rectal cancer is not recommended in this scenario, which is all patients diagnosed with rectal cancer as part of routine evaluation, in patients with bulky T3B disease with EMVI, suspected liver disease, and raised CEA. Is polling going on? Okay, so I'll ask my panelists to comment on this and also comment on what is your recommendation for staging. Dr. Nagesh, would you like to?
For staging, we usually do CT chest and abdomen to see for lung and liver metastasis. I think the only absolute indication for PET CT will be patients who have a resectable liver-limited metastasis to look for extrahepatic disease. And for patients who are on post-treatment surveillance, who are having rising CEA levels, but your colonoscopy and CT scan does not show any evidence of disease.
So you agree that all patients don't need a PET CT scan? We all agree on that?
Yes.
Any differences on the panel?
I generally advise PET CT for all locally advanced this thing, because it will obviously MRI is must for local extension, but no harm in doing PET CT in locally advanced hair rectum all patients.
So I want to dissect out this no harm. Do we do tests because there is no harm, or you think you're going to get more information? Dr. Kamran wants to comment.
Well, you know, if it's obviously metastatic disease, and on my rectal examination I find that it's quite a hard fixed lesion, I probably won't do an MRI. But I will do a PET if this patient is going to go on chemotherapy as a baseline record to see the response to chemotherapy later.
Any other comments on this? So 37 people posted that not required in all, and I at least concur with that. And in advanced disease, it is a physician's choice, but certainly if there is extravascular, mural vascular invasion and other things on MRI, on raised CEA, we need to do an PET CT in that situation. Let's move on. So I don't want to waste it or stick on this. Any role of laparoscopy in staging for these patients? Colorectal cancer, Dr. Kamran?
Not in rectal cancer. For this patient, probably I would do a CT abdomen chest.
Sorry?
CT abdomen chest as staging.
Exactly.
And no role of laparoscopy.
Yeah. So I think most people would agree that an MRI along with a CT chest, abdomen and pelvis would be a baseline evaluation, with PET CT being optional in certain scenarios, but not in all. Anyway, we did a PET CT in this patient, and these were the findings. There was uptake in the lymph nodes, local region, and finally the diagnosis was CT3, N2A, M0, stage 3. Now, if Dr. Nagesh, you have this patient, what would be your treatment plan for this patient?
These patients are usually taken up for preoperative chemoradiation. At our center, we give capecitabine along with radiation.
So I think there is very little doubt that neoadjuvant chemoradiation would be advisable in this patient. Let me ask that, are there any scenarios in rectal cancer where, Dr. Kamran, you would want to operate straight away? Any rectal cancer, I'm not talking of this patient.
Not for this kind of a disease.
Not with this patient.
Very early, probably a T1, T2 lesion. Similar MRI shows that it is restricted within the muscularis mucosa, no mesorectal involvement, no nodes, N0, then I may consider surgery upfront.
Yeah. So I think a limited role, early disease, perhaps upfront surgery would be best. So in neoadjuvant therapy, what is the strategy which you would adopt? You said chemoradiation, but you know, there is a lot as regards chemoradiation. You have concurrent chemoradiotherapy, you have consolidation, you have total neoadjuvant. So how do you pick this strategy?
So basically, total neoadjuvant chemotherapy, total neoadjuvant therapy is indicated in patients who are at high risk of having margin positive resection, particularly T4 disease, when the mesorectal fascia is involved, or node positive disease lying in lower rectum. In such cases, total neoadjuvant therapy is recommended. In other cases, it is usually long course conventional chemoradiation.
May I ask Dr. Sham, what would your advice would be for this?
Yeah, definitely. Definitely, I think this patient, when we took at that, he requires the chemoradiation therapy. Now, generally what we see that when the quite low rectal involvement is there, we give a protected chemoradiation therapy. So it should be a concurrent chemoradiation therapy and followed by a gap and then undergo surgery. But if it is a little higher up where the sphincter can be preserved, then you can give a short course of external radiation therapy and immediate surgery can be done in those cases.
So I'm glad you brought around short course chemoradiation. So what is your take in short course chemoradiotherapy? Is it limited to certain situations, or it can be applied across the board in the present scenario for patients with locally advanced rectal cancers?
So a long course of chemoradiation therapy can be applied for all the patients, which is not a problem as such. But when I see the sphincter is well preserved, it's away from that, and you know about your surgeon, then you can take the short course of radiation therapy.
Dr. Kamran?
You know, I'm from the era where we used to operate upfront for rectal cancer. And I'm so happy that we are able to give chemoradiation now. Because the whole scenario is different. The surgery becomes so much easier. The local control is so much better. I don't believe in short course in a patient like this. If it's a localized disease, it's long course capecitabine with radiation.
So for this patient, elderly patient, multiple comorbidities, can such patients be considered for short course radiation if they are not considered deemed for long course radiation?
I may consider short course if the lesion is high, just below the peritoneal reflection. It's somewhere T2, T3, I'm not very sure, then short course. Or if it's a metastatic disease and I quickly need to remove the primary which is bleeding and it's borderline T2, T3, give a short course, go ahead and do surgery. Otherwise, I prefer long course.
So can I add? Actually, the standard of care is 5 weeks of long course radiation with concomitant capecitabine. The short course is used, Swedish study is there, but no chemotherapy was given with that 20 gray 5 fractions. And mainly the surgery was done early in the short course arm. However, the late toxicity of short course radiation is much more as compared to the protracted one. So we should stick to the protracted course now. Probably that is a better way to downstage a disease and operate.
So I'm a bit surprised that the radiation oncologists are for pro long course. I will just share some data with you. But before that, how much after the chemoradiation therapy should surgery be done? What is your take on that, Dr. Kamran?
Anything between 6 to 8 weeks,
Okay.
or even 5 to 8 weeks.
6
But
to
I
8
operate at around 6 weeks.
Right. Any differences? What would the radiation oncologist suggest? No. So I think let's put this poll to the audience. Which of the following statement is true for short course radiation therapy? Is usually not a component of neoadjuvant chemoradiotherapy protocols, is contraindicated in locally advanced disease. The recommended interval between RT and surgery with short course is 6 to 8 weeks, and all of the above. Started the time? So, I'm a little foxed by these responses, but we'll come to that. I think everything is acceptable in a certain sense, but my correct answer is C in this. And see, now there is a lot of data which is talking of short course chemoradiation therapy compared with long course therapy. And this is a meta-analysis very most recent, and there are multiple meta-analyses which have showed that short course chemoradiotherapy has increased pathological complete response, better downstaging, lower lymph node positive, better disease-free survival, and no difference in toxicity and types of surgical procedures. As a matter of fact, from Lucknow, this is a very interesting study which was done from KGMU comparing long versus short. And what they found is there's reduced treatment delays and higher rate of compliance in treatment, as a matter of fact. There's no difference in early oncological surgical outcomes. And in time and resource-constrained developing countries, short course may be a standard of care in this patient. Though the earlier recommendation with short course from the Scandinavian trials was early surgery. That was for not very advanced disease, but now with even advanced disease, T3, T4, short course with a prolonged period is as good as a long course radiation chemotherapy. And just a word about total neoadjuvant therapy versus the standard CRT. The pathological complete response rates are much higher, but whether it really translates into survival and disease-free survival, we don't have enough data. But in some series, there is increased pathological complete response rate and disease-free survival rates. And these are also systematic review and meta-analysis comparing these two. Nevertheless, as all the panelists mentioned, neoadjuvant concurrent chemoradiotherapy with capecitabine, long course therapy, radiation was given, followed by a consolidation chemotherapy of FOLFOX regimen was given. So once you do this, as Dr. Kamran, you mentioned that you like neoadjuvant chemotherapy, and Dr. Nagesh also recommended that. When do you evaluate the response post neoadjuvant chemotherapy? And how do you evaluate the response?
About 4 to 5 weeks, or around 6 weeks, a good digital rectal examination, and probably repeat an MRI. If I feel that originally the disease had a high metastatic potential, I may add a PET scan or a CT to see whether there has been any progression or any metastasis developing during the neoadjuvant therapy.
Absolutely. Dr. Nagesh, you agree with that?
Sir. 6 weeks post completion of chemoradiation.
So I think basically closer to the time when you are prepared to operate, which is around 6 to 8 weeks, you want to stage this disease again and see the response. Absolutely right. That is what I would think most people would recommend. But any thoughts on how do you diagnose or assess that it is a complete clinical response? Dr. Kamran?
So we again, on digital rectal examination, if I find that the mucosa is completely smooth, it's a normal rectum. Sometimes you might find a small area of fibrosis or a lot of hardening in the rectal wall. And I think the most difficult to judge is when there is stenosis, because you don't know whether there may be disease within the rectal wall. So it's a combination of digital rectal examination, if required a biopsy on endoscopy, but these are not easy to biopsy and very often you get fibrotic tissue. And then on MRI, I think that's the best we have. And you judge on that. And there are patients where I'm convinced that there's a complete response. We keep them on follow-up. And especially those patients where there is likelihood that they will lose their sphincter.
Absolutely.
And it's ambiguous, whether there's been a response or no. There's some fibrotic tissue. I explain to them and keep them on a close follow-up every 4 to 6 weeks. And then we decide.
Right. So I think what is the encouraging part?
Or even other option is they go ahead with their systemic chemotherapy and then we keep them under surveillance. But if it's a straightforward surgery, which I can do a low anterior resection, then we go ahead with surgery.
So what is encouraging is now we see about 15 to 20% of complete response, clinical complete response, and this idea of assessing them for complete response is very critical. And as you said, by all means, what you have. Dr. Prasanjit, any point in biopsying, and does it help at this stage?
See, if you look at a study, it was done by a group from China, and it was published in Scientific Reports in 2016-17. They did a very good study, and they showed that post-therapy neoadjuvant, the tumor can either shrink towards the mucosa or there can be fragmentation of the tumor. It regresses, but there is fragmentation. So if you are taking a biopsy from the mucosal side, they showed that the residual cancer cells are present in mucosa in only 20% cases, whether it is in submucosa in 40%, and around the muscle around 80% cases. So chance that if you are taking a biopsy, you will miss the residual small group of cancer cells. And they showed the sensitivity would be around less than 15%. But when you see that tumor, the specificity is obviously very high. So biopsy will not be a very good modality to assess the response.
So only a biopsy may often miss, right? Yes. Digital.
I think I agree that digital rectal examination is the most important thing.
Yes.
And invariably, after a month or 4 weeks, 6 weeks, you are examining and you find some induration there. better to give a course of antibiotic and then you examine the patient, because sometimes there is an element of infection, maybe after 6 weeks. That's a different.
So, I mean, once there is a suggestion that there is a complete response, I think, as Dr. Kamran suggested, clinical examination, imaging, maybe visualization by sigmoidoscopy, and if there is evidence that there is a complete response, then perhaps one could adopt the policy of wait and watch under close supervision. So this patient had a MR after the full Fox, and the upper panel is the recent one, which showed some response, but still there was sphincter involvement of this patient. So MRI was done and assessment was performed. Dr. Nagesh, what further?
I think in view of this mesorectal infiltration, this patient can be considered for total neoadjuvant therapy.
Okay. Any others? Opinions?
Sorry, what was the response like? I couldn't read all that.
It was not complete. There was still involvement of the levator ani. The local disease had regressed to a certain extent.
Surgery.
And lymph nodes had regressed.
Surgery.
So even I agree, direct surgery, because probably further giving any neoadjuvant treatment will not result into further responses. So it is better to go in and operate patient early.
Yeah, agree.
Okay. I don't have an audience question on that, but we thought, yes, Dr. Jagannath.
That question about a complete clinical response, and Pran said that how frequently do you bugger them? Every 6 weeks you bugger them with a PR?
So it's Dr. Kamran.
I think that's the simplest method of keeping them under observation. We are surgeons, our fingers speak to us. So yes, that's the simplest way. Are you going to repeat an MRI every month, every 6 weeks? And are you going to risk a surgery and then see there's a complete clinical response? Then how do you feel about that?
On a more serious note, I don't think I would get a PR done every 6 weeks. That's terrible. Now, I would say that if we have this group of people who are responders, whom you know very well, I think it would be interesting, maybe Anita's insights in maybe who are the people who are responding. If
Yes.
that kind of a prognostication by any means is there, then it would be really a very useful thing.
Any molecular markers on that?
As of now, Dr. Jagannath, it's very difficult to predict who would have a complete response. But I think there are some studies which have shown that type like a KRAS mutation would not respond well, whereas a wild type may respond well. Some of these markers are there, but you can't preempt what kind of response. So you'll have to look at that. So anyway, this patient, we felt that should get more chemotherapy, but she was not willing to get any more, and it was planned for surgery. So, Dr. Kamran, what's surgical strategy?
You know, in the last slide, there is just something which I want to... Is there any role for putting this patient on chemotherapy now? Because as you said, with short course and with chemotherapy, you're getting better complete response
I wanted
rates.
to. I wanted to.
I have no answer.
Because,
it's a question.
it's as Dr. Nagesh said, that perhaps these are the patients who are losing their sphincter.
And should we,
are good for
and should
total
we be giving
neoadjuvant.
that option to the patient? Look, I can operate you now.
We gave that.
Or I can put you on chemotherapy and
We did
bugger
give
you
that.
every month.
That's what.
I mean, what would you prefer?
I wanted to do that.
And there's no scientific reason why we can't give that offer to the patient.
We can absolutely give, and that was offered to the patient, and that's why I mentioned that was not willing for because of the response she got, and we have to respect that.
Because no patient is absolutely ready for surgery unless it's really necessary. You know?
Yes. So how do you decide what kind of surgery, sphincter preservation, whereas as opposed to a AP resection?
So
At what stage? Pre-treatment?
4 centimeters, again, I will bank a lot on a good digital rectal examination to see the mobility of the rectum, where the fibrosis is, where am I getting normal rectal tissue distally. Look, the endoscope can't feel. And then plan a surgery and keep it in mind that this is at 4 centimeters, it's very much possible to preserve the sphincter. And yes, I'll do a frozen section at the time of surgery and then decide whether I can really preserve the sphincter on table or no.
So,
with probably a covering colostomy, ileostomy.
What I was trying to understand is that is pre-treatment evaluation tells you whether you can preserve the sphincter, and conversely, which patients convert from non-sphincter preservation to sphincter preservation?
If I have normal rectum, even 3 centimeters distally, then I'm a little more upbeat about preserving the sphincter. But I have a lot of lateral rectal spread, and I find that the lesion is fixed. Even if I save the stricture and have a distal negative margin which is negative, my anastomosis is going to get stenosed because of that lateral rectal spread. So in that case, I may go for a
So generally, pre-treatment you would make, unless it's a bulky disease which you are going to shrink, but you have enough rectum, then those you would convert from in order to get a CRM. Yeah. Let me see. This is again question for you. Open versus robotic or versus laparoscopic?
This is now, again, I was an open surgeon, and I watched laparoscopy with some inquisitiveness, and then with some interest, and then with alarm. And by the time I learned laparoscopy, and I was happy doing it, robotics came. So this is my philosophy. I do almost everything laparoscopically now, unless it is really low. If the patient is obese, then robotics has a great advantage. If the patient has a lot of comorbid conditions and cannot tolerate high abdominal pressures, then robotics we can do at pressures of 7 to 8. So obese patients, lot of comorbidities, very low AR, robotics is actually cost saving. Otherwise laparoscopic. Open is very much there, and if I find that the disease is very bulky and I may not, it's a very narrow pelvis, then open is also an option.
Fantastic.
This is very interesting. You know, in robotics, and this is something fascinating I discovered about myself, we as open surgeons could feel in open surgery, but robotics took away my tactile sensation. And there is an instrument in robotics which is called the bipolar. It's a traumatic instrument. Initially, when you hold the bowel with it, it slips, but it tears the serosa. So in my early cases, when I used the bipolar, without tactile sensation, I used to tear the serosa. After about maybe between 70 to 80 robotic cases, I was using that traumatic instrument on the IVC without tactile sensation to milk a renal vein thrombus from the IVC into the renal vein. So robotics takes away your tactile sensation but compensates with your visual sensation. And at that time, if I had realized it, I would have really been scared. But later on when I saw the video, so you don't need tactile sensation in robotics.
So, I mean, absolutely agree with what you have said, and that's the trend these days, minimally invasive surgery with minimal morbidity and short length of stay. Anyway, we need to move on. So we did a laparoscopic assisted APR, and patient did well and went off. This was the final histopathology report. Dr. Prasanjit, you want to just highlight that what are the important components of a report, and how is tumor response grade important for us to understand what to expect in this patient?
See, I'll start with the tumor regression grade. There is a lot of question which tumor regression grade should be followed. Actually, all of them show at least moderate inter-observer agreements. So anyone can be used, but we commonly use Ryan's because it is very easy to reproduce, as well as the CAP one, the same thing. And Other things, always, most importantly, we should give a quantitative tumor regression score. That is, what is the tumor burden versus the fibrosis. That should be always given. But most importantly, what I say, I will highlight here, that pathologists don't follow the ProCare protocol. There is a Belgian ProCare protocol which was developed for this purpose, which says that there is a specific protocol we should follow for the sampling. At least 5 sections should be taken from the area of scarring. If there is no tumor, then the whole fibrotic area or the tumor bed should be sampled again. And even if there is no tumor, all blocks should be cut in 3 planes, deeper planes. And after doing all this exercise, if there is no residual cells or tumor, then only we should give it as a complete tumor regression grade. So that should be always followed.
Thank you. Just one more question I have. That do you also in your specimens post neoadjuvant therapy see less number of lymph nodes?
That is very logical. We see less number of lymph nodes.
So the same criteria of adequate lymphadenectomy and number does not apply to neoadjuvant, post-neoadjuvant?
It doesn't apply, but if we get around 7 to 8, we are happy with that in this kind of specimens.
Okay. Thank you very much for that case. We'll do a short case if it's all right. We still have about 13 minutes. This 52-year-old lady presented with multiple liver metastases secondary to rectosigmoid cancer. She had anorexia, weight loss, ultrasound showed this lesion. She had diabetes. This was the lesion. Biopsy was moderately differentiated adeno-CA. And some cuts, which I'm showing, is a localized rectosigmoid or upper rectal disease. This is the CT scan showing multiple SOLs in the liver, predominantly in segment 4, 5, 6, and 8, and one on the segment 4 sitting right on the vein of the middle and right middle hepatic vein. So this was the workup. CEA was 32, PET-CT was done, which highlighted these lesions. Colonoscopy biopsy was done, and biomarkers, it was RAS, NRAS, BRAF, wild type, and MRR proficient. So, audience poll in this, in patients with synchronous liver metastasis in colorectal cancer. Long-term outcomes are poorer with left-sided and rectal cancers. Synchronous minor resections are also not recommended in patients with rectal cancer. Liver-first approach is the preferred approach in large volume disease with asymptomatic primary, all of the above. It started? All? No? Okay, let's move on. We don't have much time. So, so we can have show of hands. Okay.
Show of hands.
So one major, Dr. Jagannath is not participating. So we have one less vote on that. All of the above. I'm afraid C is the right answer. Let's go on. What is the role of biomarkers in clinical practice in this kind of scenario, Dr. Nagesh?
So this primarily depends upon whether patient is having resectable liver metastasis, conversion chemotherapy, whether we are going to consider for unresectable but later can be considered for resection, or whether it is totally palliative. So if it is resectable, so basically go for surgery and then adjuvant chemotherapy. If you are considering for conversion chemotherapy, definitely we are going to consider for biomarkers which had been mentioned, the extended RAS, BRAF testing, and again MSI testing. And in metastatic setting, again MSI, extended RAS, BRAF, HER2, the NTRK, all the molecular panel has to be done.
So you're suggesting no need in metastatic disease to do biomarkers in all. Suppose I argue that why not do it in all, so that you can look at what kind of chemotherapy and outcome parameters can also be assessed based on the biomarkers.
You will do it, but if it is potentially resectable, there is no role of any targeted therapy, biological agents. So
fair enough, fair enough, fair enough. Now, what about the liver approach, Dr. Kamran?
Well, if the volume of disease in the liver is more and the primary is relatively asymptomatic, then upfront, for this kind of a patient, upfront chemotherapy, the moment I feel it becomes resectable, we go for a liver first approach. And there need not be a very big gap in between the two. You know, something like this can laparoscopically be done very easily. And maybe even a week or two later, you can do the liver. So both ways it's okay. There's no harm in doing a liver first approach because there is a larger volume of disease in the liver.
So you are okay with liver first?
I'm okay.
You're okay with liver first. You also want chemotherapy?
Yes, chemotherapy.
So you want liver first, chemotherapy?
No, chemotherapy first.
Chemotherapy,
Then assess the
reassessment,
response. Yeah,
resection, and then primary. Any other thoughts, Dr. Nagesh?
yes, sir, definitely. Same, I agree.
You agree with that approach. Dr. Jagannath, you have any other suggestion?
In this specific case, if you see the primary, it's a very bulky, narrow disease. I think, yes, chemotherapy first, see the response, and possibly get the primary first. Because if you see the bilobar metastasis, it'll be, it's not an asymptomatic primary. This is obviously likely to be a symptomatic
should
primary.
not be a problem. Laparoscopically, you
It
can get
was
this primary out.
not
And
symptomatic, this
But
primary.
very bulky lesion, I think, fine. But it really doesn't make
it won't make a difference either way. The issue is that if you have given upfront chemotherapy and you're going to wait for your liver resections for 6 weeks, during that time, can you deal with the primary? I think you can.
Okay, so I think there are a lot of options which are available. I'm just going through some of them for the purpose of the audience, in the sense that you can do depending on the extent of disease involved. And here, since it is multiple, either it is 2-stage or it is 1-stage liver surgery with portal vein embolization. And as we have discussed, and this is a lot of data again is available on this, and which strategy is better for synchronous lesions. And this is one of the recent ones which shows that stage strategy, which is simultaneous, bowel and liver, staged is better, especially when you have to do a major hepatectomy, and it also translates into better survival and recurrence-free survival. And the interesting part about liver first is that you are able to complete treatment in a majority of patients, which translates into overall survival. So 80% completed the treatment. So we also adopted the liver first strategy in this. We also gave chemotherapy in this patient as neoadjuvant chemotherapy, FOLFOX 3 cycles. So this was the thing, but the problem is about the volume which this patient had. The volume was not adequate for doing a primary upfront surgery, so liver augmentation had to be done. So portal vein embolization was done, and followed it during the waiting period. We did chemotherapy for this patient. There was increase on hypertrophy about 22% in this patient, and subsequently patient underwent a modified extended right hepatectomy, tolerated the procedure well. 4 weeks later, she had a laparoscopic anterior resection with primary anastomosis and post-adjuvant therapy. So any comments on anything you would do differently in this?
Sir, any role of any marker placement before you subject these patients for neoadjuvant therapy?
I think that's a good question, that if there is a response, what would you do for the missing or disappearing colorectal liver metastasis? Dr. Kamran?
Disappearing colorectal liver lesions,
Yes.
nothing, observe. Treat the primary and keep them under surveillance.
Sorry?
Treat the primary, keep them under surveillance.
I'm sorry, I didn't get it.
You mean to say there's been a complete response of the liver lesions? I wouldn't operate on the liver.
Okay. Dr. Prasanjit, you want to say that when there is a complete radiological response, if biopsy is done, is there any residual tumor in that? Do you
I
have
could
any?
not get your question. It is echoing.
Suppose there is a complete radiological
The
response.
biopsy still show that there is disease.
Is it a true
yes,
complete
yes.
response?
Discorrelation can be there because when especially there is only few residual tumor cells or there is a small cluster that has been reported, there can be some discorrelation.
One of the things
Pathological
is that,
response rate is actually low, even if there is complete clinical response.
sorry?
Even if there is complete clinical response, pathological response will be less.
Yes, yes, absolutely. So there is a lot of controversy regarding the disappearing colorectal liver metastasis, and it's not believed that it is a complete response. Unless it is a single lesion which has disappeared, then you may want to keep it under close follow-up. But if there are multiple lesions, one of them has disappeared, you would want to tailor your surgery based on what the pre-treatment status was and resect all that was pre-treatment also.
One has disappeared or all have disappeared? One has disappeared or all have disappeared?
One, usually
Okay,
one
then
of them
if one has disappeared,
disappears.
we'd still operate.
and,
But what if all have disappeared?
I wonder, single ones, it can happen.
No, I'll tell you my problem is that these treatments are so extensive. See, we look at all the literature and all that, but in reality, most of my patients with metastatic colorectal cancer don't complete treatment.
Don't complete.
It's
Yes.
just the socio-economic implications of what we are talking over here. You can't just say liver first and if it disappears, you operate or don't operate, because at least in my practice, the patients are bankrupt by the time they've reached over here. So there has to be some consideration of the socio-economic aspects when you decide on these treatments.
No, you're right, absolutely. But on the other hand, if you see the benefit these multimodality treatment has brought to the outcome of these patients, it's a tough thing to question that whether we should do it or not do it. So I think this is my last slide, and then we could invite comments from outside. Trends and changes. Actually, we are fortunate to be in a situation where there are tremendous changes, and it has made a great impact on the outcome of patients with colorectal cancers and liver metastasis. First one, of course, is MRI, which has made local staging really remarkably good. The new adjuvant chemoradiotherapy, and as I said, and I showed you enough data, that short course is perhaps as good, and as Dr. Kamran mentioned, as far as the compliance and cost, it will be better for our people in that scenario. Of course, in certain situations, the total neoadjuvant with complete pathological response and wait and watch has saved many sphincters. And minimally invasive, laparoscopic, and robotic has also made a great impact on decreasing complications, R0 rate, CRM, complete CRM resection. So all these components, along with precision medicine based on biomarkers, it's just a great time to be in treating colorectal cancers. Not to forget that all this under the umbrella of multidisciplinary tumor board, which will determine for each patient what the best form of treatment is. From my side, thank you very much, and thank you for my panelists for contributing to this. And there is a minute and a half, and if any comments from the floor, I'd be happy to have the panelists answer that.
This particular case, you would actually flip it, because by the time you had the embolization volume, as the Kamran would just go in and then take out the primary and walk on the liver.
We use that period to give chemotherapy for this patient, for neoadjuvant chemotherapy. So
I mean, that's about the only thing I would feel that I would rather focus on this. And as many times we have seen, if you see the number of MCRCs which we are resecting compared to the West, it's less.
Yes.
Less.
Yes.
And the number of MCRCs, okay, metastatectomies are all fine. Number of MCRCs which are actually needing a major liver resection is also less. So where we need to balance out.
Why, if there was a solitary lesion which was easily resectable
solitary
like left
is all
lobe, I
fine.
wouldn't even give chemo. I would operate both together and then give chemo.
No, not that. In this particular case.
In this
Bilobar.
And in response to your question regarding the biomarkers in a non-metastatic, I think with MMR in all cases, you can do BRAF mutation, especially if it is non-metastatic, because if in a left-sided carcinoma BRAF mutation is there, then the treatment outcome will be expected to be poor. So that can be considered in all cases.
Right.
So, Kamran, one last question for you. In which situations in T3 lesions would you operate primary?
Sorry, what did you say?
T3 lesion, when would you operate primarily? First surgery, then the rest?
Quick answer.
If it was above the peritoneal reflection, if it was below, maybe I'll see and then give a short course and do it.
Thank you very much.
I want to get some, physics funders on this short course business. Now, what exactly are we trying to achieve? Are we going to say that, okay, in 5 days later surgery, the margin, everything is sterile, and then the tumor shrinks? What is the funder in this 5 days radiation, and 5 days after that you do surgery?
See, the margins will not be sterile immediately, but those cells will not be able to multiply. That's the 5 days there. You are giving a high dose. Like for all benign lesions in the brain, we are giving the similar kind of thing. So in those 5 days, those cells will not be positive, will not be multiplying there. Though when you take a biopsy, possibly they may be there,